Hi everyone, and welcome to the 10 on 10 series, day 10, where we are going to discuss PYQs of microbiology. But there's a particular topic of path and micro combined that I have picked up for the PYQs, and I'm sure all of you have written it so many times in the comments through these days that I had to take it up in one session. So here we go with a very quick review of most important topics from immunology. But before that, yesterday's homework was ATP 7A gene mutation because 7B was seen in Wilson disease and 7A, as told rightly by you in the comments yesterday, is Menkes disease. And also the canals of Herring, which are present in the liver, they contain the oval cells, which are the stem cells of the liver having regenerative ability. So let's get going on day 10. If you remember, the last slide where we left yesterday was to do with the graft versus host disease, and this is a question that I explained to you in the PYQs. Continuing on the same and talking about transplantation, here you have a woman who has received an allogenic bone marrow transplant 3 weeks ago for acute myeloid leukemia, so a blood cancer. She complains of a skin rash, diarrhea for 3 days. A skin biopsy is showing lymphocytic infiltration in the dermis and the epidermis, along with apoptotic cells in the basal layer of the epidermis. Liver is also affected because AST, ALT, the liver enzymes are elevated. Now they are asking you which cell is responsible for it. So if you look carefully, we have three organs, that is skin, intestine and liver affected. The same three that I told you yesterday were affected in case of graft versus host disease. So now why is it occurring? Like I told you yesterday, I shall tell you once again, it is the donor's immune cells which are going to come and attack the recipient. So let's revise it one more time. When we talk about graft versus host disease, the graft, let's assume the bone marrow transplant or the graft that has come, that is highly immunocompetent. So that has a lot of immune cells like the lymphocytes. They are going to come and attack the host because the host over here is highly immunocompromised, low in immunity. So obviously the donor immune cells, that is the lymphocytes, will come and attack the host, and three organs are affected, that is the skin, intestine and liver. That is why there is a skin rash, there is diarrhea and liver enzymes or liver injury seen over here. So if it occurs less than or within 100 days of the transplant, it is acute GVHT. After 100 days happens to be chronic GVHT. All of these we studied yesterday, so this was a clinical application of the same. Let's move forward and do that. This was an allogenic bone marrow transplant. So what are the different types of grafts? That's the next question, which they'll give you the 4 types of grafts, then you'll have to match them with how you describe them. So the first one is autograft. Autograft means from one person, maybe the skin from one part of the body has been put to another part of the body. So in other words, it's an auto, self-grafting. The next is going to be isograft. So iso is going to refer to identical twins. So if there is grafting between identical twins, that is isograft, I for I of course. Then comes allograft, which is most commonly done in kidney transplants, bone marrow transplants. We take the kidney from another human being. We take the bone marrow from another human being. So this is a transplant which is done between same species, that is allograft, and over here allogenic bone marrow transplantation was mentioned. The lastly is xenograft. Xeno means different. So over here we've taken some amount of tissue from some foreign species. That could be an animal like a pig, etc. And this is very commonly done for prosthetic heart valve, where different animal prosthetic heart valves are taken and then they are implanted into the humans. So these are also 4 surgery PYQs that have been asked to you. Let's move on to the next question. They've asked you what is true regarding MHC. All are true except, and as I go through it, MHC is going to be made up by a gene that is known as the HLA gene, which is present on chromosome 6. So this is definitely going to be a true statement. Now this HLA gene is going to be of 3 types. HLA gene is of 3 types, but it is only HLA gene 1 and 2 which are going to make MHC 1 and 2. There is nothing known as MHC 3. HLA gene 3 does not make MHC 3 because MHC 3 does not exist in literature. So over here it says class 3 MHC. Now that is totally wrong because there is nothing known as class 3 MHC. Yeah, if they would have written third type of HLA gene, that would have been correct, but class 3 MHC is the false and the answer over here. But this means all the others are correct. So now what I'll do, I'll quickly revise in 2 slides regarding HLA and MHC and we'll come back to the question. When I talk about major histocompatibility complex, it is made up by the HLA gene which is present on the short arm of chromosome 6, so that is 6p. Now revising quickly, if HLA gene is present on chromosome 6, then what else? There's one gene of hemochromatosis, iron overload, HFE, that is also on chromosome 6, and a type of polycystic kidney disease which is autosomal recessive polycystic kidney disease. The gene for that also happens to be on chromosome 6, not of autosomal dominant polycystic kidney disease because chromosome over there is 16 and 4 multiples. For autosomal recessive, it is chromosome 6. Now coming back, HLA gene, when I talk about its structure, it is going to be divided, like I told you, it is going to be of 3 types. So it's going to have 3 areas, HLA gene 1, then comes HLA gene 2, and then HLA gene 3. What did I tell you? From HLA gene 1, we are going to code for something that is known as MHC1. From HLA gene part 2, we are going to code for something known as MHC2. But HLA gene 3 does not code for any MHC because MHC3 does not exist. In turn, HLA gene 3 codes for certain complement proteins, especially the early complement proteins like C2, C4, even properdin that comes in the alternate complement pathway. Then it codes for certain proteins like TNF alpha and heat shock proteins. So complement proteins and other proteins is what HLA gene 3 is going to code for. Now before I talk about MHC1 and MHC2, I can see that HLA gene 1 and 2 further have some parts. HLA gene 1 has part A, B, C. Then we take a break, go to HLA gene 2 where the Ds are present, that is DP, DQ, DR, and then we come back to HLA gene 1 where the remaining alphabets beyond D are there like E and G. This is very, very important for you to know. So now talking about the structure of MHC1 and MHC2. So for MHC1, we will go in a particular direction first, that is alpha chain. So these will go as alpha 1 chain, then alpha 2 chain, then alpha 3 chain. What is the separate chain lying over here? That is going to be beta 2 microglobulin. Versus for MHC2, the way you write 2 over here as 2 up, down, 2 lines, you are going to go up, down like that also, like it is alpha 1 and alpha 2, beta 1 and beta 2. So these are the chains. Why is it important? Because they want you to know where is the antigen going to come and sit. You can see the antigen always sits at the top. So what is the antigen binding cleft of MHC1? It is at the junction of alpha 1 and alpha 2. And what is the antigen binding cleft of MHC2? It is at the junction of alpha 1 and beta 1. The next question is that where are MHC1 and 2 present? Which kind of cells are they present on? So MHC1 is present on all the nucleated cells of your body. Every nucleated cell will have MHC1, but RBC does not have a nucleus, so RBC does not have MHC1 obviously. Even the sperms do not have MHC1, whereas MHC2 are particularly present on the antigen presenting cells. So now it's obvious that where they are present, how will they hold on to the antigen, but now the next question is, which cell will they give the antigen to? This antigen has to be given further to some cell. It has to be presented further. So MHC1 will present it to CD8 T cells and MHC2 will present it to CD4 T cells. And I hope you've not forgotten the rule of 8 in immunology. Whenever you are confused that MHC1 presents to CD4 or CD8, the total has to come out to be 8. So it has to present to CD8 because then 1 8s are 8. Similarly, if MHC2 you are confused that what will it present it to, that has to be CD4 because then it is going to be 4 2s are 8. There's another place in immunology where we follow the rule of 8, and that is the ratio of CD4 is to CD8. Again, many students say it's 2 is to 1, some say it's 1 is to 2. Remember, the normal ratio is 2 is to 1 because again you have to do 4 2s are 8 and 8 1s are 8. If you ever write it as 1 is to 2, you will never be able to get that combination. So when in doubt in immunology, go for the rule of 8. Now coming back to the question that we had over here, that does chromosome 6 harbor the gene HLA gene? That is correct. The genes encoding for complements are adjacent to MHC. Yes, MHC 1 and 2, and the genes encoding for complement is in the center, which is made by HLA gene 3. So this is also correct. Monocytes have MHC class 2 on their surfaces. Right now you said that MHC class 2 is present on the antigen presenting cells. Which are the 3 main antigen presenting cells? We had learnt it by the mnemonic DBM. So DBM means that number 1 are going to be the dendritic cells. They have MHC2. Then the B cells have MHC2, and the macrophages. Macrophages, the cousin brother is monocyte. So does monocyte also have MHC2? Yes, all antigen presenting cells have MHC2. So it is DBM that have MHC2. So now the only incorrect statement is over here because class 3 MHC does not exist. Now finally moving on to the next set of questions that we have over here is regarding our antibodies. We have to do a revision of antibodies before the exam. So here we have a 19-year-old woman who comes with multiple organ complaints like malaise, there is joint pain, there is weight loss, there's intermittent fever going on since 3 months, Physical examination has shown a malar rash. As soon as you read this, definitely SLE is coming to your mind, and that does have mouth ulcers also. There is involvement of kidney. Maybe lupus nephritis is occurring because proteinuria. Maybe this is nephrotic syndrome. That is why proteinuria is happening. So now they are saying which of the following antibodies would you think of SLE? And out of the options given over here, we will think of anti-dsDNA antibody for SLE. So quickly revising all the antibodies for the autoimmune disorders, the same in the one-liner session also I had given you this. So it's a quick 30-second recap. When we talk about SLE, the most sensitive is going to be ANA, that is anti-nuclear antibody. The most specific is ASA, that is anti-Smith antibody. The one that can do both sensitive and specific work is anti-double-stranded DNA or dsDNA antibody. So we had learned for double-stranded DNA, there is a double benefit of sensitivity and specificity. Moving on to neonatal lupus, neonate always cries, so RONA, so anti-Ro antibody. And lupus with psychosis is anti-ribosomal P antibody, which we had learned as P for psychosis. This was everything to do with SLE, systemic lupus erythematosus. If we talk about which kind of hypersensitivity reaction is SLE, it is a combination of type 2 and type 3 hypersensitivity reaction, but more commonly it is always going to be type 3 hypersensitivity. And how did we learn it? You flip the 2 S, you get a 2, you flip the E, you get a 3. So this is a combination of 2 and 3. Moving on to the next, and that is Sjogren syndrome. We write SS. So the antibodies are also SS. I hope you remember clinically these patients are going to present as dry eyes because the lacrimal glands have stopped working, and the dry mouth because the parotid or the salivary glands have also been attacked. But attacked by which antibodies? That is anti-SSA, Sjogren syndrome, anti-SSA and anti-SSB. SSA is sensitive, SSB is specific, and they're also known as Rho-La antibodies. So Rho is sensitive and La is specific. Coming to now scleroderma. Derma tells us about skin. Sclero means thickening of the skin. If a limited part of the skin is thickened, that is limited scleroderma. If the total involvement of the skin occurs, that is diffuse scleroderma. So when limited scleroderma is there, means it is limited or centered to one part of the skin. Centered to one part. So the antibody is anti-centromeric antibody. But when diffuse scleroderma occurs and total skin is affected, so for total skin, the antibody is anti-topoisomerase antibody, also known as anti-SCL70, where of course SCL is going to tell you about scleroderma over here. Now coming back for SLE, they had asked you, so the antibody making sense is anti-dsDNA antibody. What you are going to write as one of the homeworks for you today is going to be that regarding C ANCA, P ANCA that we've discussed earlier, you will give me a list of the diseases which show C ANCA and P ANCA antibodies. Moving on to the next question that we have over here, which is the much dreaded, but we have to give it 10 minutes. Which is the genetic defect which is most commonly associated with X-linked SCID? What is SCID? Severe combined immunodeficiency. So now when I look at the genes over here, all of these are for SCID. But when I talk about X-linked recessive inheritance, it is going to be the gamma subunit of the cytokine receptors which is going to have a problem. So now I'm going to show you the table which all of you have always, because of which probably you tell me that I should be teaching you immunology, is the table of immunodeficiency disorders. If you look at it carefully, I'm either having a disease in which the lymphocytes B and T lymphocytes, they are not able to mature only, or they have matured but they are not able to get activated and they are not able to do their function, or there is an overall disease which is affecting many parts of the body. So let's go one by one. When I talk about problems which are coming in lymphocyte maturation, the first one is SCID. So yes, we are going to do the genetic defects of each one of these now. That's why I said 10 minutes. So when I say SCID, the genetic defect depends on the inheritance. If it is X-linked recessive inheritance, then that is most likely because of the gamma subunit of the cytokine receptors not working. So X-linked recessive is because of the gamma subunit of the cytokine receptors not working. This means interleukin 2, 7, 12, 15, many of these are eventually going to get impacted. Now talking about the autosomal recessive SCID, under which the most common one is the adenosine deaminase deficiency, ADA deficiency, and if it's not that, then it is either a mutation in the JAK3 gene or it is a defect in the RAG1 and RAG2 gene. So overall you will realize that for X-linked recessive it is the gamma subunit not working, and for autosomal recessive there has to be an element of A, that is ADA deficiency, JAK3 gene defect, RAG1-2 gene defect. So SCID is done. Let's move on to the next. Next that we have in lymphocyte maturation problem is Bruton's hypogammaglobulinemia, which you know as the BBB story, that this disease is more commonly seen in boys. It is actually a B cell problem, and the problem is in the BTK gene. Because of that hypogammaglobulin, there is a decrease in immunoglobulin, especially IgG. The next one is bare lymphocyte syndrome, previous year NEET PG question. That is a deficiency or a defect in MHC2. Moving on to the next disease under this list is the famous Dye-George syndrome, which is learnt in pediatrics as catch-22. So what is catch-22? The 22 means the 22q chromosome is basically deleted. Now this is because of this deletion that two very important arches and two organs are not formed. One of those organs is the thymus. So thymic aplasia occurs. If thymus is not formed, this means the T cell maturation is going to go for a toss. And second, the parathyroid gland is not formed, as a result of which hypoparathyroidism, which means the calcium levels are going to dip. Apart from that, there are face abnormalities, like there is cleft lip and cleft palate, because of which patient starts having an abnormal facies. And there are cardiac defects also that are noted. Many of them are noted, for example, tetralogy of Fallot. How does a question come on Dye-George syndrome is this, where they will give you a small child and the child is having multiple infections. You understand why? Because thymus is not there, T cells have not developed, so obviously infections will occur. Then you see that there are low levels of serum calcium because the parathyroid gland is not there, and they have mentioned that there are low levels of functional T cells. They are classically hinting towards a T cell defect in a young child. They've not mentioned everything like cleft lip, cleft palate. They don't want to give away the answer to you, and based on that, it is a Dye-George syndrome. So all of the lymphocyte maturation defects are done. Now I go on to the defects where lymphocytes have matured, but they are not able to get activated, and the disease is known as CVID. CVID stands for common variable immunodeficiency. So what is common to it? Because over here the B and the T cells both are affected. So how are the B cells affected? Because there is a problem in the BAF gene. And how are the T cells affected? Because there is a problem in the ICOS gene. Let me actually show you a difference. In CVID also B cells are going to be affected, and in Bruton's also B cells are affected. Then what's the difference? For that you need to understand the entire pathway of B cells. Initially B cells are babies and immature. When they will become mature, they will go and sit in the germinal center of the lymph node, and for this maturity we require normally a gene called the BTK gene. When they are mature, they will be sitting in the germinal center, and from there they have to now become super specialized. So they now have to become plasma cells and start making antibodies, and for this super specialization they require the BAF gene. So now you understand that if the BTK gene stops working, patient has Bruton's hypogammaglobulinemia. In that situation also the rest of the story will not occur and immunoglobulins will not form. Whereas in BAF gene stops working, then the patient is going to have CVID, and in that scenario also the plasma cell and immunoglobulins will not form. So what's the difference? Please note that BTK is the only defect that is occurring in Bruton's, because this is only and only a B cell problem occurring more commonly in boys. Whereas common variable immunodeficiency, this can occur in any gender. It is common. So it is not just a B cell but also a T cell problem. The B cell over here is because of BAF gene, but the T cells are also affected because of ICOS gene. What's the next difference? Now if you look carefully, in Bruton's hypogammaglobulinemia, it is the BTK gene that is not formed. This means the germinal center will never be able to form. There are no mature cells, means the germinal center is not formed. There is hypoplastic germinal center. Whereas in common variable immunodeficiency, you know that till here the pathway has been fine. This means the germinal center has formed, the mature cells have formed, so they will keep forming. And thus in CVID there is hyperplastic germinal center. So Bruton's has hypoplastic, CVID has hyperplastic. Coming all the way back, we have done CVID also. Moving on to the next. Before that, how does a question come on CVID? They will give you that there is a BAF gene defect. I think on the basis of this only you have given a diagnosis of CVID, but I told you in CVID there is going to be hyperplastic germinal center. So germinal center hyperplasia of other lymphoid areas is occurring, going more in favor of CVID. Moving on to the next. After CVID we have a lot of antibody things. First, two hypers, hyper IgM and hyper IgE. Hyper IgM is because of the CD40 receptor or ligand defect, and very commonly for NEET PG students you should know it is associated with pneumocystis carinii infections. And hyper IgE syndrome, where IgE of course is more, that is also known as Job syndrome, and we always want to leave the Job stat. So that is going to be the stat gene defect that you are going to see over here. This is hyper IgM, it increases, hyper IgE, it increases, but the next one is isolated IgA deficiency, means only IgA is going to be missing in this person. The question that comes only for NEET PG's exam is that if there is a person who has only and only a deficiency of isolated, only IgA is deficient, what kind of a blood transfusion would be given. If this person ever happens to have a road traffic accident and he is in requirement of blood, what kind of a blood would be given to this person? Because of his immunoglobulin deficiency, you will have to give him washed RBCs, means red blood cells that have been washed with normal saline, so that you are getting red blood cells from a donor. Maybe that donor or has normal IgA antibodies, but these people have never seen any IgA antibodies in their life. So if you start transfusing IgA antibodies to them, it will result in a reaction. So you will have to wash the RBCs so that all the IgA is removed, and then these RBCs can be given to such people in case of emergency. So you are done with the activation defects also, which leaves you last with the systemic diseases. 2. Wiskott-Aldrich syndrome and ataxia telangiectasia. There is ataxia telangiectasia, of course, ATM gene is the defect, and the name tells you that patient will be having ataxia, patient will be having angioectasia. Ectasia means dilation, angio means blood vessel, so dilation of the blood vessel along with ataxia, and there's of course an immunodeficiency. Now moving on to the Wiskott-Aldrich syndrome. So if you take the first three alphabets, WAS, the name of the gene is the WASP gene, and the P over here we have learnt as platelet. There is a platelet problem. Yes, these patients are going to have a small sized platelets. The only disease in pathology and microbiology where small sized platelets will be mentioned is Wiskott-Aldrich syndrome. Of course, patient because of that will have bleeding, and along with that patient will have infections also, and patient will be having eczema as well. One more question for Wiskott-Aldrich syndrome, which is a previous year question, is going to be the immunoglobulin profile. I had told you W ulta karo. So what goes down? IgM is going to go down. So there's a decrease in IgM, and all the other antibodies like IgA and IgE are going to increase. But what is going to remain normal? IgG is going to remain normal. Why am I emphasizing on that? Because if IgG would have gone down, it would have become hypogammaglobulinemia. I would have thought more in favor of Bruton. So out of this table, if I just have to revise the antibodies, in hypogammaglobulinemia, most commonly IgG goes down. In hyper IgM, IgM increases. In hyper IgE, IgE increases. In isolated IgA deficiency, only IgA decreases. In Wiskott-Aldrich syndrome, IgM goes down and all the other antibodies are going to go up. Finally, we have wrapped up with this entire situation, and now we move on to the next question, which is again something which will come in a twisted format, one of the tougher ones. So let's go. Which of the following is the correct definition of a hapten? Let's go one by one. Is hapten belonging to different families that share epitopes due to which antibodies cross-react? No, that is the definition of a heterophile antigen. What do you mean by heterophile antigen? For that, you first need to understand what are epitopes. Whenever you say antigen and antibody ka reaction hua hai, it is not that the full antigen and the full antibody are going to bind to each other. No, the antigen has small parts called epitopes, and the antibody has a area that is called paratope. So it is the epitope and the paratope that is binding. Today onwards, don't call it antigen antibody reaction, call it epitope paratope reaction. So now there are, let's assume this is antigen number 1. Similarly, we have another antigen called antigen number 2, then antigen number 3, and all of them are sharing the same epitope. Some of their epitopes are looking like twin brothers, they are looking very similar. So don't you feel that this antibody will then be able to react with epitope of antigen 1 and antigen 2 and antigen 3? So there is not going to be a specificity. That means this antibody can cross react with multiple antigens, and that is what is written over here, that there are different antigens, but they share the epitopes due to which the antibodies will cross react. Is that a hapten? No ma'am, that is a heterophile antigen, so this option is ruled out. Is hapten the one that is going to activate more than 20% T cell activation? Again ruled out. You know who does that? That is the work which is done by a superantigen. This is the photo that you need to remember. Quickly making you revise what a normal antigen is. Whenever a normal antigen comes into our body, that antigen is going to be picked up by a cell called the antigen presenting cell, and the antigen presenting cell, let's assume this yellow color antigen, it is going to be kept on which part of the antigen presenting cell, which I taught you as the second question today, that is it will be kept on MHC, and then it will be presented to what? It will be presented to the T cells. Do you see where have I kept the antigen? I have kept it at the junction of that alpha 1, beta 1, the center. That is how a regular antigen is processed and given to a T cell, but then super has to be something different. Super decided that I'm not going to go by the general public line. I am going to take the VIP entry from the side because I want things to happen faster. So it decides that I am going to attach laterally, and you can see over here how it has attached laterally. This lateral attachment is what makes super antigen the super, and when it does this VIP entry from the side, do you know how much of T cell activation will it cause? More than 20% of the T cells are activated. T cells go crazy. They secrete cytokines like crazy. There is a massive cytokine release, and that is responsible for toxic shock syndrome, like you study in a case of Staph aureus. So what they are writing over here is more than 20% is not a hapten, it's a super antigen. Let's read further. Hapten is something that shows binding capacity but is not able to induce an immune response. Well, that happens to be correct statement, and that is the answer for what is a hapten. Please note, hapten is referred to as an antigen, but that is an incomplete antigen. What do I mean by a complete antigen first? First, let's understand that what is antigenicity and then what is immunogenicity. Antigenicity always means that coming and binding, that the antigen is able to bind, that is known as antigenicity. After that, it should be able to induce an immune response, means it should be able to activate your immune system, and that induction of the immune response is known as immunogenicity, which means that if there would have been a complete antigen, it would have had complete properties. It would have been able to bind to the cells also, it would have been able to induce the immune response also, it would have had antigenicity also and immunogenicity also. But when I talk about hapten, उसमें कुछ incomplete है ना, something is missing. It is able to bind, means it can show antigenicity, but it cannot activate your immune system. It cannot show immunogenicity. So ma'am, what can I do? If I ever have an incomplete antigen and I want to convert it into a complete antigen, I will have to bind it to some carrier. Usually we use protein carriers in the lab, and when you will add that protein carrier, then it will become complete, and then it will be able to do all the activities. So what is hapten? Hapten is an incomplete antigen which can definitely bind to the cells, but it cannot induce an immune response, and that is the correct statement. What is option 4? Gamma globulin. Totally wrong. Gamma globulins are immunoglobulins, they are not haptens. So of course this is a very, very tough question. Of course you have not studied this in rapid revision, but then that's what immunology is. Moving on to the next set of question, which is an easy one. All of the following are true about IgA, except IgA was the recent INI set question, so I expect something related to this, probably in NEET and FMG also. So what is IgA? A for A, it is going to activate which complement pathway? The alternate complement pathway. Please note, there are two main, actually there are three, but the two main complement pathways that you are asked in the exam is the classical complement pathway and the alternate complement pathway. So it is IgM and IgG which are going to activate the classical complement pathway, and it is AD. So AD is going to go and activate the alternate complement pathway. So this is correct. How many types of IgA do we have? IgA1 and A2. Yes, there are two subclasses. That is again correct. It is also known as mucosal antibody or secretory antibody. That is true because it is present in all the mucosas of the body. It is present in your GI mucosa. It is present in your lungs mucosa. So every time you are inhaling a lot of dust and bacteria, this IgA is protecting you. Every time you are eating street food with a lot of bacteria, viruses, parasites, this antibody is protecting you. It's in the mucosa. Secondly, it's present in breast milk, for example. So body secretions also have IgA, hence secretory antibody. So all are true, except it is the only immunoglobulin to show a transplacental spread. No, IgA does not. In fact, this is the answer because it is IgG that is going to show the transplacental spread. But what was the recent INI-CT question? It was the image of IgA. Remember that I can see IgG, E and D over here. They are coming as monomeric form, single. IgA can exist in single form also, and it can exist in this double form, which is known as the dimeric form. And when it will exist in a dimeric form, it will be combined with something known as the J. I have made a J, so that this is the joining chain. There is a center fevicol that I have added. But if you're Indian, you know that if you have to send a parcel to someone's place, do you think by putting one tape, your inner self would be satisfied that your parcel is intact? No. Ma'am, we as Indians, we will first put a little bit of fevicol, and then after that, to get over our anxiety, we will double tape it, and we will make sure that the parcel is very secure, and that is what the body did. First, it joined the two antibodies with a J chain, and then it decided that I am going to double tape it so that it is secure, and that is known as the secretory piece. nice. So there are two things which are actually joining the IgA antibody. Again, an extra information that I'm giving you. Coming to IgM, I can see that there are a total of 5 antibodies that are connected by the joining chain, and because of this, this is known as the pentameric antibody. Because it has everything so much in abundance, it is also known as the millionaire antibody, because you can see it's got 5 together. But if you ask me about the concentration, which was last year FMG exam question, we learn it as GAMD, which will tell me that IgG is going to have the maximum concentration, and moving on from there, IgE is going to have the minimum concentration. What other question can come over here? Is a 22-year-old man who presents to the clinic with itching, hives, and difficulty in breathing after consuming a special type of seafood. Have you started thinking of some kind of an allergy? Yes. Yes, there are allergens in spring which are troubling this person. There is urticaria. So they are talking about type 1 immediate hypersensitivity. Which antibody? IgE. So IgE will be elevated in allergies. IgE will also be elevated in parasitic infection. That could be the future exam question as well. Moving on to the next question that you have to know, which is not everyone's favorite but the last for the day, and that is going to be, what is the main purpose of direct ELISA? And I know you were waiting for this. Firstly, before I just move on to reading this entire question, not to put you into any kind of depression, I will quickly do a scan through of the different types of ELISAs in 5 minutes, and then we'll solve this question within seconds. So let's understand what is ELISA. ELISA is enzyme linked. So I will be using an enzyme immunosorbent assay. Enzyme linked immunosorbent assay. This is an ELISA plate where you have 12 wells over here and 8 wells over here. So total obviously becomes 96 wells that I have. I can do so many tests in one go. So of course it's very beneficial. Now, before I move on to direct, indirect, etc., what am I using? In every ELISA, I will be using an enzyme known as horseradish peroxidase. Even if you remember HRP, it's an enzyme, ACE, chalega. Whenever there is an enzyme always breaks a substrate. So, ma'am, that substrate you only have to provide. You will be adding a substrate called H2O2. Of course, if you use the enzyme peroxidase, the substrate that it will break will be hydrogen peroxide. So, that's also learned. But in the end, can you see there is a color? Some wells are showing a dark blue color, some are showing a very light blue color, some are showing even light, almost colorless. So some color has been added. Usually the color that we add is related to benzidine. So 3 things you will have to mug up, and then I'll explain. The enzyme is HRP, the substrate is H2O2, and the chromogen is benzidine. Now coming to the different types of ELISA, you've read about direct, indirect, then sandwich, and then competitive ELISA. What are they detecting? If you look carefully, so ma'am, in a patient, what will they give me information about? All the ELISAs, if you look carefully, are giving you information more about antigen. So direct ELISA tells you about antigen, sandwich about antigen, competitive about antigen. It is indirect ELISA which will be able to detect the antibodies. It's so important to know this, because at least you should know now what are you trying to search for in the patient. Now no one is asking you the entire protocol, but if you know it, then you will be able to solve questions. So now just know that whatever type of ELISA I will do, these are the 3 things I will have to add. Only then will I get this color in the end. I will have to add an enzyme, a substrate, and a color. So let me start with direct ELISA. What am I trying to do it for? Ma'am, everything is for antigen. So what sample will I take from the patient? The sample, whatever blood sample or whatever has been taken, that should have the antigen. Let's assume for the time being my patient has the antigen. So this is the sample that I've added. So patient has done his part, and now everything I have to do. So if patient has given me an antigen sample, I have to add an antibody, and then after that, what are the 3 things that I should be added? This antibody is going to be linked with an enzyme. Read the definition of ELISA again. It is enzyme linked immunosorbent, means the immune antibody that you will be adding, that antibody will be linked to an enzyme. So now you understand, I've added an antibody which is linked to an enzyme. Ma'am, if you've added an enzyme, then you have to add the substrate. Only then the enzyme and substrate will react. You're trying to create a chain, and if they will react, how will I get to know they have react? I will have to add a color which is benzidine. More the amount of color that I will get in the end, I will get to know more the amount of antigen that the patient has. So for example, this patient over here with the deep blue color has a lot of antigen concentration. This patient with a very light blue color has a very less amount of antigen concentration, and that reading the computer and the software does. So overall, I realized that first thing is what you add is what you want to see in the patient. After that, you add the same enzyme, the same substrate, and the same chromogen. Let's look at what I've done for indirect ELISA. Because in indirect ELISA, I want to test what? I want to test antibodies. So now, ma'am, from the patient, I am going to get antibodies. But I can't just put antibodies in the well, right? That antibodies will always go and attach to some antigen. So this is something that you will first have to add. If this is your antigen or this is your ELISA well, first you will have to prepare something in your lab and you will have to add the antigen. On top of that, you are going to add the antibody that you have got from the patient. Patient will give you antibodies. Let's assume you're trying to look out for COVID antibodies or hepatitis antibodies or whichever antibody. So this antibody sample you have added. But this is the antibody from the patient. Is it enzyme linked? No, your method is enzyme linked ELISA. So now you will have to add another antibody on top of it which is linked to the enzyme. If you put the enzyme, you will have to put a substrate. That substrate will be broken. Then you will have to put a color, and then you will ultimately be able to tell that if the color intensity is very, very dark, that will automatically tell you that there was a lot of antibody detection seen in the patient. So overall, it's the same. You just need to know what sample and how are you processing it. Moving on to sandwich, the name only tells you. Sandwich is also now everything else is also going to be antigen detection. So ma'am, sandwich means that if you're trying to test for antigen from the patient, आप उसका sandwich कर दो. How should I create a sandwich? This is the antigen that I want to detect in the patient. I will now sandwich it between two antibodies. One antibody which I have kept here and one antibody I have kept here. Have I managed to create a sandwich? Have I trapped the patient's antigen between two pieces of bread and created a sandwich? Yes, once you have done the sandwich, rest of the story is the same. There is an enzyme linked antibody that you will add. With the enzyme, you will add the substrate. With that, you will in the end add the color. So more the intensity of color you will get, more the concentration of antigen patient has in the body. So that is a sandwich ELISA. So coming back, when I detect antigen in the patient, direct ELISA. If I want to detect antibody in the patient, that is an indirect ELISA. If I want to detect antigen in the patient by creating a sandwich, that is a sandwich ELISA. So now comes the toughest and the last one, and what is competitive ELISA, which will actually remind you of a lot of people in your class and your batch. So now let's assume that this is a classroom which is scheduled for tomorrow and the teacher will be teaching you tomorrow, but there will always be some student who will quickly read all of that lecture one night before in the hostel without telling anyone, but will finish off that topic so that he can give more answers in the class. I'm sure you thought of someone from your batch. So this means that before whatever I add in this, I have done some extra step outside the ELISA plate. What is competitive ELISA done for? It is done for antigen detection. Means what is the sample that I'm going to get from the patient? I am going to get an antigen, but I'm not directly adding it into the ELISA plate. I'm finishing off the syllabus outside. I am taking the patient's antigen and I am going to make it react with an antibody outside only. I have created an antigen antibody complex chupke se outside. Now I'm going to take that complex and now I'm going to put it in the ELISA well, and then I'm going to do the same direct ELISA procedure. I will first put an antigen, then I will add a secondary antibody. That antibody will be linked with an enzyme. This means after the enzyme I will add the substrate. After that I will be adding the color. Everything else will be the same. But tell me something, if I had already done the homework from beforehand, do you think I'm going to pay much attention in class? Because I have already finished off the syllabus. I already know all the answers. So if the antigen has already reacted with all of the antibodies outside the well, now on adding it into the well, is it going to show any reaction? And is it going to show the final color? It will not. So this means if the patient had antigens, you have already done the reaction outside. This means the further reaction will not end up giving you any color. So in the end, if you don't get any color, this means the patient had antigen and all of the reaction occurred outside. It's opposite happening over here. Abhi tak you had studied that more color you get, more antigen patient has. It was a direct correlation. Now it's the other way around. The more color you get in the end, this means more reaction has occurred inside, and this means the patient did not have any antigen outside. Repeating once again, over here what did I say? Patient had antigen, all the reaction occurred outside. तो कोई भी color नहीं आना चाहिए था. There is no color. So if there is no color, this means the patient has a lot of antigen. Ulta. And over here, if you see a lot of color, then that would mean that the patient does not have any antigen. So it's the inverse thing that happens in competitive ELISA. Very commonly done for hormones such as free testosterone, etc. So coming back to the question which where we were stuck at, what is the main purpose of direct ELISA? Think of your answer. Direct ELISA is for what? It is for antigen detection. Let me see. Does the assay measure the concentration of antibodies? No, galat. I don't want to read the rest of the statement. Does the assay measure the concentration of the enzyme enzyme HRP? Totally wrong. Does the assay measure the presence of antigen in the patient sample? This is making sense. And the intensity of the color is directly proportional to the concentration of the antigen. For all the ELISAs, the intensity of the color is directly proportional except competitive. I've got my correct answer. Let me read the last one. The assay measures the concentration of H2O2, again wrong. So now you know direct ELISA measures antigen, and more color you get means more concentration of antigen in the patient. Well, I've tried my best to summarize ELISA for all of you, and that of course brings you to the last question of the day, which I've revised so many times, but I still want to do that one last time. When you're doing antigen antibody reactions, you will come across this agglutination test. You know, cat sat on a mat. You've given me in the homework answer. So 10-second revision from my side. These are three tests: cold agglutination test, standard agglutination test, and microscopic agglutination test. We had learnt it as cat sat on a mat. So this is cold, standard, and microscopic, and cat is known as Billy, so we go for my Billy, which means that cold agglutination test is going to be done for mycoplasma, the one that shows fried egg colonies. Standard agglutination test is done for brucella, which is a zoonotic disease. It comes from animals and animal milk. And lastly, the INI set question, that is microscopic agglutination test, is done for leptospira. Leptospirosis asked recently in INI set, so that's why I'm revising this for you. Well, with that, with all the nostalgia, we are ending with 2 rounds of the 10 on 10 that we have finished in this particular 1.5 month, and it's been quite a journey. I will be sharing this entire PDF of the all 10 days, although I believe if you just viewed them even once through these days, don't waste your time. You have exams coming up in, for NEET and FMG very soon. So don't waste your time going through this PDF, but I will definitely be putting across the PDF to you. And I will also be waiting for the homework answer because it's the last class, and I hope all of you will be telling me the homework answers today as well one last time. I will be meeting you again for wishing you all the best before the exam, but in case you miss out on that video, sending you all the love, blessings, prayers, and I hope this happens to be the best day of your life. You give your best attempt, better than any GT, better than any test that you have ever given, and I'm very sure that you will come with smiling faces on the other side. I'll be meeting you very, very soon. All the very best, guys. God bless you.